Assalamu alaikum warahmatullah. Our talk today about leishmaniasis. Leishmania divided to visceral leishmaniasis and cutaneous and mucocutaneous leishmaniasis. Visceral leishmaniasis, also called Calazar, caused by Leishmania donovani parasite, and the cutaneous one caused by Leishmania tropica or Leishmania mexicana or Leishmania brasiliensis. Visceral leishmaniasis or Calazar, the life cycle involves the sandfly female as the vector when they take blood meals. The ducks, foxes, and rodents are reservoir when the sandfly sucks blood from an infected host. These ducks or foxes, it engages the macrophages containing a mastigot. A mastigots. This picture for the sandfly. After dissolution of the macrophages, a mastigot differentiates into what is called pro-mastigot in the gut of the fly. The A mastigot ingested from the reservoir, ingested as A mastigot in the gut of the fly, transform or differentiate to pro-mastigot. That's mean the stage in the reservoir is A mastigot, but within inside the fly differentiate to the stage called pro-mastigot. Okay, they multiply and then migrate to the pharynx where they can be transmitted during the next bite. The cycle in the sandfly takes approximately 10 days. This diagram explains the life cycle in the insect. They insect the mastigot, okay, and go to the gut of the fly, change to pro-mastigot within 7 days, then inject it again in the skin as pro-mastigot. Shortly after an infected sandfly bites a human, the pro-mastigot are engulfed by the macrophage of the human being, where they transform again into mastigots. The infected cells die and release a mastigot that infects other macrophages and reticuloendothelial system. The cycle is completed when the fly ingests a macrophage containing the mastigot. This is the life cycle in the human and reservoir animal. The pathogenesis, the organs of the reticuloendothelial system, which is the liver, spleen, and bone marrow, is called reticuloendothelial system, are the most severely affected, and this results in, once the bone marrow is affected, that's mean can lead to anemia, low leukopenia, decrease in the white blood cells count, and even thrombocytopenia, decrease in the platelet count. This leads to secondary infection and tendency to bleed. Once there is thrombocytopenia, this can lead to bleeding. There is leukopenia, that's mean the secondary infection can be occur, and so on. Once the liver is and spleen infected, that means the patient may be presented by hepatomegaly or splenomegaly. Enlargement of the spleen is due to a combination of proliferating macrophage and sequestered blood cells in the spleen. Leishmania are intracellular parasite, and the control of infection is by cell-mediated immunity. Hence, HIV/AIDS will alter the clinical pathology of leishmaniasis. A person co-infected with HIV and leishmania suffers severe acute visceral leishmaniasis because he has a low cell-mediated immunity. HIV and immunosuppression can also result in latent leishmania infection becoming clinically overt. What is the clinical finding? Clinical finding: intermittent fever, weakness, weight loss, massive enlargement of the spleen, as we said, and hyperpigmentation of the skin. Untreated severe disease is nearly always fatal as a result of secondary infection. As we said, there is leukopenia and thrombocytopenia. The patient may die from the bleeding or from secondary infection. This patient infected by visceral leishmaniasis observed is very enlarged because of enlarge of spleen and enlarge of liver, hepatomegaly, and splenomegaly. Diagnosis by detecting the A mastigote, which is called in the bone marrow leishman donovani bodies الاختصار بتاعها LD bodies in a bone marrow or spleen or lymph node biopsy. We take a bone marrow biopsy or spleen or lymph node, and when we see it under microscope, we can see these LD bodies or the A mastigote. Also, can we do serologic indirect immunofluorescence tests are positive in most patients. The A mastigote inside the macrophage, these LD bodies, A mastigote inside engulfed by macrophage. This diagram to differentiate between the shape of promastigote and amastigote LD bodies, which will be seen inside the macrophage under the microscope. Treatment: sodium stibogluconate or amphotericin B is also effective. Prevention from leishmania involves protection from sandfly bites. Use the net or protective clothing or insecticide spraying. The second type of leishmaniasis, cutaneous and mucocutaneous leishmaniasis, from the name, affect the skin and mucous membranes. This can be caused by Leishmania tropica and Leishmania mexicana. Both cause cutaneous leishmaniasis. Leishmania brasiliensis causes mucocutaneous leishmaniasis. Sandfly are the vectors for these three organisms, as they are for Leishmania donovani, and forest rodents are their main reservoir. The life cycle of this parasite is the same as of the Leishmania donovani. The lesions here are confined from the name to the skin in cutaneous leishmaniasis and to mucous membrane, cartilage, and skin in mucocutaneous leishmaniasis. Granulomatous response occur and necrotic ulcer forms at the bite site. The lesions tend to become super infected with bacteria. The epidemiology of cutaneous and mucocutaneous old world cutaneous leishmaniasis, called oriental sore, caused by Leishmania tropica, is endemic in the Middle East, Africa, and India. New World cutaneous called bay sore, caused by Leishmania mexicana, is found in Central and South America. Mucocutaneous leishmaniasis, called spondia, caused by Leishmania brasiliensis, occur mostly in Brazil and from the name of the species and what is the clinical finding? The initial lesion of cutaneous leishmaniasis is a red papule at the bite site, usually on exposed extremity. This enlarges slowly to form multiple satellite nodules, like multiple satellite nodules that coalesce and ulcerate. There is usually a single lesion that heals spontaneously in patients with a competent immune system. This diagram explains the formation of cutaneous leishmaniasis. At the beginning, the sandfly inject the promastigote. Then there is core of cells parasitized by a mastigote formed. There is cellular infiltration. Then there is necrosis and ulceration. Then there is secondary infection. This will lead to the ulcer formation. Then granulation. Then can lead to repair, healing and repair, but in immune competent patient. Look to the picture of cutaneous leishmaniasis to look to the ulcer. However, in certain individuals, if cell-mediated immunity does not develop, the lesion can spread to involve large area of the skin and contain enormous numbers of organisms. Mucocutaneous leishmaniasis begin with papule at the bite site, as we said, but then metastatic lesion form usually at the mucocutaneous junction of the nose and the mouth. Disfiguring granulomatous ulcerating lesion destroy nasal cartilage but not adjacent bone. This lesion heal slowly and take very long time. Okay, this diagram explain the area can be affected by, in the mucocutaneous leishmaniasis, in the ear, in the nasal, in the mouth. Okay, look for the mucocutaneous leishmaniasis, how can affect the skin and destroy the cartilage and the skin. Laboratory diagnosis microscopically by demonstrating the hemastigmat in a smear taken from the skin lesion. Leishmanian skin test also, it is delayed type cutaneous hypersensitivity response to intradermal administered leishmanial antigen becomes positive when the skin ulcer appear. Treatment also sodium stibogluconate. Prevention involve protection from also by using netting, window screen, protective clothing. There is another topic for leishmania called post-Calazar dermal leishmaniasis. This is a complication of visceral leishmaniasis, latent period from 0 to 6 months, usually 3 months after the patient affected by visceral leishmaniasis. These can be macular, papular, or nodular, may be itchy. There is hyper or hypopigmentation. Start around the mouth, spread to cheeks, forehead, and scalp, then to the other sides. Mucosal lesion also may occur, and most are self-limited. And that is all about leishmania. Thank you so much and good luck.